So today we're looking at making life easier with assess, prepare, treat, and looking primarily at wound infection. We know as clinicians, identifying wound infection can be complicated, managing wound infection can be complicated, and hopefully at the end of the next hour, we'll give you a bit more confidence in managing infection, looking for the signs and symptoms of it, and also at the end there'll be a pathway that you'll be sent. So that will hopefully give you some support in education to move forward within your clinical areas. Tippy tappy not working. So the objectives for today. During this session, we're going to introduce you to the Coloplast three-step approach, which is a step-by-step framework to effectively assess, prepare and treat infected wounds and biofilms. So it's really important that we really robustly assess patients with wounds and ensure we prepare the wounds and treat them with the most simplified approach. Throughout this session, we'll learn a simplified approach to wound healing. And I think that's a real key. It's looking at wound healing rather than wound management. For a long time, we've talked about wound management, but we really need to change that language and look at wound healing, progressing those wounds to actually get the outcomes for the patients. Understanding the impact of wound infections and biofilms, how the biofilms interact within that wound bed and actually halt and make those wounds static. So we're going to have a look at that. We're going to look at the wound infection continuum as well. Gain an overview of the latest principles of best practice from the International Wound Infection Institute. And like I said previously, we're going to leave you with the Coloplast three-step approach wound infection pathway to support you out in your clinical practice. So, burden of wound care. We know that recently we've had those two studies from Julian Guest. If you're not aware of them, they're real pivotal studies that look at the burden of wounds and the costs incurred when we're looking at wounds. So the two papers, one was written in 2012-13 and one was written in 2017-18. And, you know, when we think about that, that's actually, this data is 5 years out of date. And when you look at these numbers, if you just think to yourself, do you think these numbers are going down? Do you think the amount of money that we're spending on wounds is reducing, or do you think actually it's increasing? Realistically, I think we know that we're spending more and more money. We're having more patients with wounds. We're having more patients with really complicated wounds. We're having a lot more younger people presenting with really complex wounds. So back 5 years ago, there were 3.8 million patients with a wound that were managed by the NHS annually. And that's 3.8 million patients that the NHS knew about. How many patients are actually managing their wounds at home with no healthcare professional support and not thinking that they actually need to get some specialised help to progress wounds and just is part of their everyday. The annual cost of managing wounds that healed was estimated to be 2.7 billion compared with 5.6 billion for those 30% of wounds that didn't heal. So obviously we're spending a lot more money on wounds that aren't healing. Why is that? If you've got a wound for longer, it's much more susceptible to infection. If that wound's present, there's going to be a bacterial burden. There's going to be that biofilm that's going to make that wound static and not progress. When wounds become infected, you incur further costs. There may be further costs with antimicrobial dressings, antibiotics. Potentially, if that wound continues to spread, patients may end up in hospital. They may need further diagnostic tests looking at if there's any osteomyelitis. So if there's any infection down to the bone, they may need ultrasounds to see where wounds are tracking off to. So all of these incur additional costs. We know as well that there's, from Julian Guest, that the cost annually of managing a leg ulcer that's not healing is £3,700 a year. And that's just for not healing a wound. So when you look at all these figures and think about the costs, we need to be changing our outlook. We need to be progressing these patients to healing. It's estimated 59% of chronic wounds healed if there was no evidence of infection. So, You know, if once you've got an infection in that wound, that's compared to that 45% where there was that definite or suspected infection. So once you get infections, you're much more longer going to have that wound, which is going to incur those further additional costs. In evidence, we know that the prevalence of biofilm in chronic wounds may be greater than 80%. So if you've got a chronic wound, 80% of them to 100% is coming out in further evidence, will have this biofilm. And we'll talk more about biofilms as we go through. 46% of healthcare professionals believe that infection is a challenge when treating wounds. And actually, I think that that percentage could be a lot higher, because identifying infection can be really challenging, especially when we've got patients with really complex needs. So what's the clinical relevance of wound infection? So it's complicated, often difficult to identify. We know that we have our normal microorganisms sitting on our skin. When we have a break in the skin, they can then infiltrate into that wound bed. And wound infection occurs when those microorganisms move deeper into the wound tissue and they start to proliferate, and they cause those local and systemic immune responses. So you get those signs of local infection, whether that's subtle signs or those more classic signs. The host immune system and species of organisms will also influence the development of wound infection. So dependent on what microorganisms are within that wound will determine whether they're more likely to have wound infection. In the event of an infection, what happens? So the wound healing is delayed. The patient's quality of life can be adversely impacted. So when that wound's infected, you often get a higher increase of exudate. So that obviously has a big impact on the patient's quality of life. I don't know if any of you have been out shopping and maybe around the supermarket, you've seen people with carrier bags tied around their feet. I know for me, I've seen people with wet, leaky bandages around their legs. When you're looking and you have a knowledge about wounds, you start identifying things you see out in your day-to-day lives. Odour also has a massive impact on a patient's quality of life. Some can become really socially isolated. They don't want to catch the bus. They don't want to go into a clinic because they're so aware of the smell. Some don't even want family to visit because that odour, that smell has such an impact on their quality of life. Also, the treatment costs rise. So within treatment, we talk about the treatment of the actual products, but that's very minimal in terms of the costs. It's actually the clinician's time. So if a patient's got an infection, you would generally need to increase visits or do dressings more regularly. So that's a cost of you as a clinician. You may also need to address more dressings because you'll need your compression bandages. And you also need to look at your wound management practices because you will become more resource demanding in a work environment where workload is increasing, workforce is decreasing. When we're putting those extra demands on the resources, it's just going to keep impacting everybody. So with a holistic approach, a proper assessment and early intervention, many of these problems can be avoided and clinical outcomes improve. So like we always say, prevention is much better than cure. If we can avoid wound infection in the first place, the outcome's going to be much better for the patient. So I'd like to introduce you to the Coloplast three-step approach. So this is about simplifying wound healing. As clinicians over the years, we've made wound healing really quite complex, but it doesn't need to be. And with these three simple steps, you can move patients into a healing trajectory with their wounds. So that step one is the assessment. Assessment is paramount in defining your treatment objectives. So within Coloplast, we use the triangle of wound assessment, which is a holistic framework that allows practitioners to assess and manage all the areas of the wound, including the peri-wound skin. So it's the wound bed, the wound edge, and the peri-wound skin. It's really important to assess those three areas of the wound. But it's also really important to assess that patient, look at their age, their mobility, their comorbidities, what medications they're on. Also looking at their psychosocial factors. What's their environment like? Are they working? Do they have any mental health issues? And addressing all of these and optimizing your patient as much as possible to get them into a healing trajectory. Then we move on to step 2, which is that prepare. So it's removing the barriers to healing to create that optimum wound healing environment. And within Coloplast, our product is an all prep pad, which again, we'll look at further on through this presentation. And then we move on to our step 3, which is your treat. So within Coloplast, we have a portfolio of dressings to manage any wounds of any depth and stage of healing. But what's unique to Coloplast is we have this 3D fit technology. Again, when we look at that simplifying wound healing approach, this is a dressing that conforms to the wound bed to manage exudate, which is a unique thing to Coloplast. And again, we'll look into it into more detail. But by completing that really holistic assessment, understanding what your treatment objectives are, you will then be able to choose the most appropriate dressing to manage that wound. We're going to go through each step now. So we're going to start with that assessment, what we need to look at in terms of managing that wound to progress it to wound healing. So what's the aim of the wound assessment? Is to identify the cause of skin breakdown. If we don't know what the cause of the skin breakdown is, how are we going to stop it continuing to break down further, and how are we going to have that prevention? So when we think of leg ulcers, it's really important to identify, is it a venous leg ulcer? Is it an arterial leg ulcer? Is it mixed etiology? Because actually, do we need to correct or treat that underlying cause? Does that patient need strong compression to actually manage the wound and put it and get it to heal? We need to identify the associated risk factors and again, manage those and optimize them for the patient as much as possible. And you need to control the wound related symptoms. So we've talked about exudate, odor. Are these causing the patient issues? Do we need to manage these to ensure that wound doesn't break down further? Because if you've got that exudate sitting on that peri-wound skin, it's just going to cause further excoriation and increase the size of the wound. It also helps in identifying the patient's expectations. You know, patients often will say, how long am I going to have this wound? Well, actually, if it's been present for 6 months, realistically, we're not going to heal it in the next week. So you can have that discussion, that dialogue with your patient. You can give them how they can support their own healing. So if they're diabetic, how can they manage their blood sugars better to get it into a more healthy range? Nutritionally wise, do they need more protein in their diet? What can they do to manage and progress their wounds? And it's also providing that psychosocial support and promote that patient's independence. Often patients walk in and they just want to give you their wound and don't want to take any responsibility. But I think we need to change the mindset. Actually, it's the patient's wound. We're happy to help them and give them guidance, but they need to help themselves as well. And we need a much bigger focus on that supportive self-management to give those patients that independence. How often should wound assessments be carried out? So a holistic wound assessment should, as a minimum, be carried out every 2 weeks in an acute setting, every 4 weeks within a primary care and community setting. But that doesn't mean that every time you take a dressing down, you are obviously doing a wound assessment. But that's the more holistic, full wound assessment, patient assessment. So it's really important when we're doing our assessments that we listen and we look. We have to be mindful that actually the patient is the expert in their wound. They often know a lot of the history, and we have to listen to them, what's happened within their journey with this wound, who they've seen, what's worked, what hasn't worked. And it helps you build that rapport with the patient. You need to look at medications. Often when I had a clinic, patients would come in with their scripts, but actually when you delve into it, they were adapting or omitting some of those medications because they didn't like the side effects. So it's really important to address what they're actually taking as opposed to what's on their script. When you generally meet a patient, you're automatically looking at how they're mobilizing. You're looking at their general demeanor. Are they anxious, tired? And you're making those observations. Are they sweaty? Are they in pain? And it's really important. I used to hate it when I went out with the district nurses and they'd have taken the dressings off and put them away in the bin and clean the leg, which was lovely. But I always wanted to see what the previous dressing was. I wanted to look at the dressing, see what color the exudate was, because it tells you so much. It's also important to check other areas of the skin of the patient, because actually, if you're looking at a leg ulcer from one leg, it's really important to look at the other leg, because actually you need to do that comparison. You need to look for skin dryness, dehydration. Is there exudate? Is there breakdown? Is there excoriation? If you're looking at the pulses within the feet, are they present or are they absent? When you talk about pain, it's also getting those descriptive words. Is it burning? Is it hot? Is it itchy? Is it shooting? All of these, again, just help you build that assessment and that picture for that patient. When you're looking at the actual wound, is there inflammation? Are there those signs of infection? And also skin sensitivity. Is there numbness, burning or tingling? Because again, that will tell you quite a lot about the type of pain they're in. We've discussed this quickly, but odour is really undervalued during skin assessment. It's so important because it tells you so much about the patient. So I used to see patients that would come into the clinic and often you could see if they had urine on their bandages, and that would give you that indication. Obviously, you would have that conversation very sensitively with that patient, but if they've got urine on their bandages, they're obviously struggling to get to the toilet in time, and it leads you to have that open and honest conversation with your patient. Also, odour can tell you things about the type of infection. So if I say Pseudomonas, everyone, if you've seen or smelt Pseudomonas, straight away it's got a very distinct smell. The same with malignancy. I think it's quite a sweet and a different smell. And once you smelt it, it's quite distinctive. So certain wounds, malignant wounds, will have a certain smell. Wet, necrosis, that dead tissue, again, all gives that indication of what's going on. And we need to manage it, and we need to, you know, when you look at that photo of the leg, you can imagine what that's going to smell like. And actually, we need to really quickly get that sloughy, soft necrotic tissue off that leg, because until you've done that, that smell's still going to be there for that patient. So this again is the triangle of wound assessment. So it's looking at the wound bed, the wound edge and the peri-wound skin. And it's to support that optimal clinical decision making to all the areas of the wound to make sure that you're optimizing it for healing. So when we look at the wound bed, we're looking at the tissue type, the exudate, and if there's signs of infection. So tissue types: necrotic, sloughy, granulating, epithelializing. Hopefully you're all aware of this, these terminologies, but I'll just give you a quick overview. So necrotic, that's that sort of black, dark, hard, dead tissue. It can be hard, it can be soft. Sloughy, that previous picture was a great example of that sloughy tissue. So it's fibrin, dead cells, and again, it needs to be removed. Granulating, that nice pink new tissue that presents itself. It's called granulation tissue because it actually looks quite granular within the wound bed. And then you've got your epithelialization, which is that top layer of skin. It's very vulnerable and delicate when it first comes across, quite pale, but that's your epithelial cells coming across. Then we look at the exudate. So we're looking at the volume. How much is present? Is it very, very dehydrated? Is the wound quite dry? Is it quite a high level of exudate? Is it leaking through dressings? Is it quite thick or is it thin? What color is it? Is it clear? Is it straw colored? Is it plurulent? Is it pink? Is it red? All of these are indications, and you need to be recording this and looking at them in depth. And then when we look at infection, we look at those sort of local signs of infection, really classic signs: pain, erythema, edema, warmth, increased exudate, delayed healing, friable granulation. So that granulation tissue, it's often quite dark in colour. And as you cleanse the wound, it bleeds really easily. That shows that there's a bacterial burden within that wound. It's not healthy pink granulation tissue. Smell tells you a lot, like we've said, and pocketing. So areas of the wound may start to deteriorate. And then you have those signs of spreading and systemic infection. So you have that increased erythema. The patient may start getting pyrexia. There may be abscesses or pus collections within the wound, and the wound will break down. I used to always hate it if I went to a patient and I sort of said, you know, how are you feeling today? And they said, I just don't feel right. That was a real warning sign for me. I'd get my obs out and do something, because when they're feeling like something's not quite right, that's often your first sign something's there's that sort of spreading systemic infection going on. Then we look at the wound edge. So we're looking at, you know, is the wound edge macerated? There's a great picture there, that white ring around the edge of that wound. That's that maceration. The cells are swelling with the fluid. It's not being managed correctly. And what will happen over time is that wound will just get bigger and bigger as that maceration breaks down. You've got that undermining. And also on that picture, you know, you've got the rolled edges as well. These are really hard to manage. We need to make sure that we're recording the depth and the width of these damage areas, so that we're able to make sure we consistently are improving and we can see that healing. Then you've got that dehydration. So that wound's really dry. We need to donate some moisture into that to help the body either autolytically debride it or soften it, so we can then use some form of debridement to lift it, maybe with like mechanical debridement, to get that off really quickly. Then we're looking at the peri-wound skin. Again, we've got maceration, but it's all the way down to the heel. You can see that's really large area of maceration. If that's not managed, you're just going to break down, most probably end up with quite a large, extensive wound. Got excoriation, dry skin. I don't know if any of you have taken off TED stockings, but sometimes it can be like a snow globe where that skin's so dry. And you really need to donate that moisture, because it's really itchy for the patients. And then if they start itching, they can then cause that further trauma. Hyperkeratosis can be really itchy again for the patient, but it can feel really hard, indurated. It can be really uncomfortable for patients. We need to manage that and remove it. Sometimes you might find you get ulcers underneath it that break down as well, because you can't visualize and see what's going on while you've got that hyperkeratosis present. On the bottom picture, you've obviously got that callus that needs removing. Obviously, looks like a Charcot foot on a diabetic, and podiatry would be very much involved with that and would do that debridement. But it's not a healthy wound. It's not going to reduce in size and contract while all that callus is sitting around that wound edge. And the final one is that eczema, that excoriation. It's not going to heal when it's that painful red excoriation with the little pustules. We need to manage that. So who's at risk of a wound infection? So we've got many factors that can influence wound infection, but here's just a few examples. I'm conscious of the time, so I'm not going to go through everything, but you can see there, you know, your diabetes, if it's poorly controlled, are going to be more susceptible to wound infection, depending on what types of surgery. Medications can obviously influence wound infection as well as lifestyle choices, so alcohol, smoking and drug abuse. So these are those sort of individual factors that may make someone more susceptible to wound infection. And then when we look at the environmental factors, hospitalization is a really big environmental factor. The longer you're in hospital, the more your risk of infection will increase. If patients live in an unhygienic environment, obviously the bacteria are going to be very more prevalent within that environment to then go into your wound beds. And inadequate management of moisture exudate will also increase the chances of bacterial overload and therefore wound infection. Wound characteristics can also predispose you to infection. So again, this is a good chart to show what makes certain wounds more susceptible to wound infection. So when you're looking at those acute wounds, those contaminated or dirty wounds are going to be much more susceptible to wound infection. When I was working in community, I often had patients with skin tears on the side of their legs caused by commodes. Well, that's going to be quite a contaminated vehicle to put bacteria within that wound. So straight away, you need to be thinking, do I need to be more vigilant to look for those local signs of infection? Within chronic wounds, how long has that wound been there? And whereabouts is it anatomically on the body? Is it near the anal area? Is it a sacral pressure ulcer? Is it going to be getting contaminated by fecal matter? And the size and the depth, if you've got a really large wound that's down to bone, it's going to take a long time to heal, and you are going to be more susceptible to infection. And then when you're looking at both acute and chronic wounds, if there's necrotic tissue or a foreign body present, that's going to make it more susceptible to infection. Hematomas that aren't managed quickly and effectively, when you have that large area of congealed blood underneath the skin, again, can be a route for infection. Now we're looking at the stages in wound infection. So this is the International Wound Infection Institute continuum. So starting on the far, sorry, I've got to get my left and right. Left, we're looking at contamination. Then we move along to colonization, then local infection, spreading infection, and systemic infection. So you can see as you go along the continuum, there's an increase in that microbial virulence and the numbers of the microbes, and they're proliferating and causing more and more of a response. And above that, you've got this biofilm that sits between local infection and systemic infection. Stages in wound infection. So when we're looking at that local infection, the microorganisms are proliferating and they're moving deeper into that wound bed, and they're actually causing a host response. Like I say, it may be subtle, it may be your classic symptoms, but those microorganisms are multiplying and they're causing an actual host response. So your signs that you'd be looking for, so your subtle signs of infection are that hypergranulation, bleeding, wound breakdown, that increase of malodor and pain. And then you've got your real classic signs of local infection, your erythema, heat, swelling, that purulent discharge, that delayed wound healing, and pain and odor. Then we move on to spreading infection. This is where those microorganisms are proliferating even more, and they're starting to invade the surrounding tissue. So they're spreading further. The erythema is beyond 2 centimeters from the wound bed. The patient will show those subtle signs as well as the classic signs of local infection, but they may also demonstrate those early systemic infection indicators, so that not feeling quite right, pyrexia, sweaty, clammy. You know, we need to be doing something really effective at this point to stop them getting a systemic infection. And then we move on to the biofilm. So like I say, these biofilms sit above a local infection to systemic infection, and it's a structure of microorganisms that live in this polysaccharide film that they cover themselves in to protect themselves. So when you're using your antimicrobials, if a biofilm is present, this polysaccharide coating, they cover themselves and protects them. So you need to make sure you're disrupting and removing that biofilm to make sure that antimicrobial you're using is as effective as possible. Biofilms aren't visible to the eye, but we know that their presence is there if that wound's become quite static. It's just not progressing, and the signs of it also are very similar to that of that local signs of infection. You know, the wound's not progressing, it's deteriorating. The wounds are stuck in that inflammatory state, so there's lots of exudate present. These are all signs that a biofilm is present. So 2 common microorganisms in wounds. So Pseudomonas, over half of chronic leg ulcers will contain Pseudomonas. Pseudomonas is a real keen biofilm former, and it has that sort of luminous green look about it. So it's very distinctive, and like I say, very distinctive smell. And then you've got your Staph aureus, Staphylococcus aureus. So that's a gram-positive bacteria. Again, a very keen bioform former. 30% of healthy individuals carry it in their nose and they're not aware of it or the impact of it. But we know that with MRSA, most common, well-known type, it's still causing mortality rates of 28 to 38%. So it's still having a real impact on patients. When do we swab? Obviously, follow your local protocols and policies. But if you've got an acute wound with those classic signs of symptoms of infection, you could do a swab and then make sure that you're choosing the most appropriate antibiotic to manage those microorganisms. When there's signs of spreading or systemic infection, infected wounds that have failed to respond to antimicrobial treatment, like I say, in compliance with your local protocols. But when you're looking for those drug-resistant microbe species, and when maybe you're going to do skin grafting, for example, and you need to assess the area of skin to make sure that there's no microbes that are going to make that procedure not go ahead. So that was a quick whistle-stop tour on assessment within the Coloplast 3-step approach. And now we're going to be moving on to our next step. So we've done step 1 and we're now moving on to our step 2, which is prepare. So like we said, slough, non-viable tissue and biofilms can all delay that wound healing process as they increase the risk of infection. Microbes love that environment where they've got a good food source, they've got undulating areas where they can hide in the nooks and crannies. And they can proliferate quite happily. There's a nice moisture balance there as well. It also inhibits the development of healthy tissue. When you look at that photo on the right, it's not going to heal while you've got all that devitalized barrier to healing within that wound bed. And it also limits the wound assessment. While you've got that devitalized tissue, you don't know at what stage the damage is, if it's undermining, if it's down to bone, if it's down to the structures. Until you can cleanse and debride and see that wound bed as clearly as possible, you just can't make a full assessment. And this is a really, really interesting study it's a large retrospective study of 312,000 wounds. So it's a really big study, and it was looking at debridement of, they just looked at specifically diabetic foot ulcers. And throughout this study, it showed that if you debrided a wound once a week, the mean time for it to heal was 21 days. And if you debrided it once every 2 weeks, the time to healing extended to 76 days. So this just really gives you that solid evidence that the more you frequently debride and cleanse your wounds, the quicker they will heal. And for any of you that have worked in wound care for quite a while, you'll know that any evidence around wound care is quite sparse. But this is quite a large study, so it really is reiterating the need to do that cleansing and debridement to prepare your wounds, to remove those barriers to healing, and actually getting really much quicker outcomes for patients. So there's different types of ways we can debride wounds and do that wound preparation. So you can do washing, just washing the limb or whichever area the wound is. Cleansing, so just removing the loose surface contaminants. So you could do that with sort of a bit of gauze. But then you move on to the more effective modes of cleansing and debridement. So you've got autolytic debridement. So that's where you're creating that moist wound healing environment for the body to naturally break down and remove that dead devitalized tissue. Can sometimes be quite a long process, but for some patients it's the best process for them. Then we move on to mechanical debridement. So many years ago, that would be putting wet gauze on a wound and then ripping it off once it was dry. Obviously we have advanced wound dressings now, so we wouldn't do that nowadays. But it's about doing that physical removal of devitalized tissue using friction, And we have our pads that we can do that with. And obviously within Coloplast, we have the All Prep pad that is a form of mechanical debridement. It doesn't require extended competencies and training, but you do have to have some knowledge as to why you're doing it. And it's a really quick, effective way of removing and disrupting those biofilms and removing those barriers to healing, that devitalized tissue, slough, biofilm within the wound bed. And then you've also got your biological, so that's maggots, again, applied to the wound, and they secrete an enzyme which breaks down the slough, and then they eat it, ingest it, digest it. Again, they work really well in the right wound at the right time. And then we've got enzymatic debridement with ointment and gels. Have to be careful because some can actually break down healthy tissue. And then your really skilled, extended skill competency of sharp or surgical debridement using forceps and scalpel. So international best practice for management of biofilms and infection, it actually says to use that wound preparation, so to cleanse and debride to reduce the number of microorganisms within that wound bed by disrupting and removing those biofilms. So we've actually got a picture here of the Coloplast All Prep pad in clinical practice, and it's just showing how that can be effective at removing and disrupting that biofilm and getting those devitalized tissue removed really effectively within that wound. How often will wound preparation be required? So that's down to your clinical judgment. If I revert back to that study, we know that the more regularly we cleanse and we debride those wounds, the quicker to healing. We know that it's a necessity and it needs to be frequent to actually get the results that you're needed. And it should be an approach that's taken at every wound care intervention. There are times that you should be cautious with wound preparation. So here's a few examples. So if a patient has a wound on the lower limb and is known to be diabetic, it's just having that caution, or connecting with your specialist to get additional support if you're unsure. If a patient has a known arterial flow concern, if a patient's on cytotoxic medications or immunosuppressed, also if a patient's got a fungating lesion, again, I would be using debridement or wound preparation with caution. And again, just connect with your specialist if you're concerned or have any questions to answer. So we've done our step 1, which is our assessment. We've done our step 2, which is preparing the wound and removing those barriers to healing. And now we're moving on to our step 3, which is that treatment, looking at what we're trying to achieve with our dressing and being able to manage any depth of wound at any stage of healing. So we're looking at our treat. So it's really important that we identify those treatment objectives. Wound assessment and preparation leads to the identification of those objectives to make sure that we're creating that optimum wound healing environment for the wound. So when you're thinking about your treatment objectives, you need to be thinking about your management or prevention. So were you looking to manage or prevent exudate or exudate pooling? Are you looking to protect that peri-wound skin? Is there maceration or excoriation present that you need to manage? How big is the wound? What's the depth? Is there a cavity? Is there undermining? How are you going to manage that? What dressings do you need to ensure that these areas are being looked at and moved into healing? Is there any infection and biofilm present? How are we going to manage that? Do we look at our international best practice standards? Actually, do we need to do that cleanse and debridement frequently to ensure that we're progressing the wound and removing that bacterial burden? But above all, it's really important, going straight back to that assessment, to identify any underlying causes and to actually refer on or optimize them as much as possible to make sure that that wound is then going to progress to healing. So international best practice for management of the biofilms, like we say, so that's step one. The picture before was with that all prep pad doing that wound preparation. Then our step two is about applying a barrier dressing to make sure that we're preventing that maceration by managing that exudate and preventing that recontamination. So with Biatain Silicone AG here shown in clinical practice, we know that it's going to lock away that bacteria with its lock away layer on the top, and it's going to make sure that that bacteria can't then be recontaminated into that wound. And then you're looking at your infection management. So you need to suppress that biofilm formation. Biofilm will keep forming really quickly. So often when we talk about biofilms, we talk about when we brush our teeth. We brush our teeth in the morning, we brush our teeth in the evening. That's because this biofilm will reform. If you run your tongue over your teeth, you might feel it feels like you've got a bit of a film. Those are those biofilms reforming. So that's why you need to use an active agent to break them down and actually kill that bacteria. So through that mechanical debridement using the all prep pad, disrupting that polysaccharide film that they've covered themselves in, you then use that active agent, which will then kill that bacteria, which will then hopefully progress that wound to that healing. So when would you use an antimicrobial? So when we're looking at this wound infection continuum, so when you're at contamination and colonization, topical antimicrobials are not indicated because the microorganisms, they're not proliferating enough to cause a host response. They're not causing any problems. The wound is continuing to heal as you would expect, and there's no issues in that healing trajectory. So you just want to be really observant, make sure that the wound's continuing to progress, doing those regular wound assessments, make sure that wound's reducing in size, and there's no need for antimicrobials at this point. When you move on to those signs of local infection, this is where you need to start using your topical antimicrobial dressings. They're indicated to be used at this point to stop that local infection going into your spreading infection. You need to manage that bacterial burden by using an appropriate topical antimicrobial to reduce that bacterial burden in that wound and remove those signs of infection. And then when we move on to that spreading infection and systemic infection, obviously your patient will require antibiotics and further escalation to ensure that they're getting the right treatment for the systemic aspect of that infection. But you still need to continue with those antimicrobial dressings because that will still be effective at reducing the bioburden within that wound bed. So at local infection, spreading infection and systemic infection, you would be using an antimicrobial throughout those signs of infection. With contamination and colonization, you do not need an antimicrobial, you just need to be vigilant. So topical antimicrobials are available in different forms. They come in liquids, paste, creams, ointments, sprays, and impregnated dressings. Some can be used every day for short periods of time. Some require reapplications, and some can be left in contact with the wound for several days. So we have more and more advanced wound dressings that actually mean you can put an antimicrobial through an advanced wound dressing and have it in place for either days up to a week. So different types of topical antimicrobials used in wound management include honey, PHMB, iodine and silver. So hopefully you're familiar with some of those antimicrobials and have used them in practice. So topical agents with silver have been used for thousands of years in wound care to prevent or to treat infection. It's been available in the following forms: so a solid elemental form, a solution of silver salts, and that was to use to clean wounds, as a cream or ointment containing silver antibiotic compounds. In recent years, a wide range of dressings contain silver, which means it's easy to apply and you're getting a sustained release of silver. So once that exudate makes contact with the dressing, the silver ions are released, and it's released over a prolonged period of time, which means that the dressing can stay in for longer. Silver has a broad spectrum antimicrobial effect against bacteria, so both gram-negative and gram-positive, and it's also been shown to prevent that biofilm formation. So silver targets multiple sites in bacteria, so it has 3 modes of action, which again makes it really effective against the bacteria. So it can bind to the bacterial cell wall and therefore blocking the transport of substance in and out of the cells. It actually transports into the bacterial cell where they then block the respiratory system, therefore destroying the energy production for the bacteria. And it also in the bacterial cell, the silver ion interacts with DNA and therefore stops that cell replicating. So it stops the replication of that bacteria. We always need to be vigilant when we're using antimicrobials and ensure they're actually being effective within that wound bed. So we often talk about the 2-week challenge. So it's about reassessing and making sure that whatever antimicrobial you're using, it's actually had an effect within that wound. If it hasn't within 2 weeks, it's not going to. You need to go back to your assessment, make sure you haven't missed anything, maybe use a different antimicrobial. And this is just a nice guide to show you. So it just shows if after 2 weeks, there's been improvement, but there's continuing signs of infection, then do continue with that treatment of silver dressing. It doesn't mean that you only use it for 2 weeks and then you stop. It's just that after 2 weeks, you do a really good reassessment and make sure there's been progression. If after 2 weeks there's been improvement and the signs of infection have gone, and stop the silver. You don't need to be using it anymore. And then again, just go back to that vigilance. Just be really mindful and look for if those signs of local infection come back. If after 2 weeks there's been no improvement, the dressing should be discontinued and consideration given to changing to a different antimicrobial agent. So here at Coloplast, we're all about making life easier. And hopefully you can see throughout this presentation that the Coloplast 3-step approach really is about simplifying wound healing using our 3 steps of assess, prepare and treat. And I just wanted to leave you with this case study about a patient that was taken from actual clinical practice. So this is a case study about Mr. D. So this was a 55-year-old male. He had a left hallux or big toe amputation due to type 2 diabetes. He had arterial insufficiency. So a really complex patient with a really complex wound. He had multiple dressings and a daily dressing change regime to manage the exudate levels. And when you look at that day 1 picture, you can see there's maceration all on that wound edge. You've got devitalized tissue sitting within. I think you can also see a bit of dressing remnants within that wound. So what they did is they did the assess, prepare, treat. So did a thorough assessment and looked at those management goals. So the management goals were to create an optimal healing environment by preparing the wound bed, wound edge and peri-wound skin. So it was to remove that non-viable tissue. They needed to manage the exudate to stop that maceration and further breakdown. They needed to manage the bacterial burden within the wound bed, making sure that they protect the granulation epithelial tissue and protect the peri-wound skin. Their prepare element was the all-prep pad to provide that mechanical debridement to remove those barriers to healing. And then for the treat element, they used biotin silicon AG, again, to manage that bacterial burden within the wound bed. When you look at the pictures, you can see from day 1 to week 9, what an improvement. And then by week 14, that wound is significantly reduced in size with a very small wound left to manage. So the results were the wound had decreased in size from 18 by 7 centimetres to 4 by 1 centimetres in just 14 weeks. And remember, this is a patient with type 2 diabetes and arterial insufficiency, so really complex. The top of the wound where the toe was now healed. The exudate level to the remaining open areas are low. There's no signs of localized infection, and the patient's pain score was only 2 out of 10 once the wound was progressing. The wound no longer required an antimicrobial to manage the bacterial load, and it was being treated with Biatain silicone. So it's just a good example of where doing that really simplified approach of assess, prepare, treat, manage this very complex patient to heal. And this is the pathway that you're going to be left with. So following this presentation today, there'll be a recording of this session where you can either look back or share with your colleagues. And we'll also send out to you this simplified wound healing pathway that you may be able to utilize within your clinical practice. So at the top of this pathway, we've got that patient, we've got that triangle of wound assessment, looking at the wound bed, wound edge, and peri-wound skin. And we are looking at the question, is the wound infected? If there's no signs of infection, we go across to the left-hand side of this pathway. So is the wound progressing as you would expect? If it is, yes, and there's granulation tissue to the wound bed, just continue preparation and the treatment plan as it is. If the wound is progressing as expected, but there's still slough and devitalized tissue to that wound bed, prepare the wound for healing using your wound cleansing and debridement. And then you would refer to the product selection guide and apply your appropriate dressing. If the wound doesn't have signs of infection, but it's not progressing as you would expect, it makes you think about suspected biofilm. If you feel that there may be a suspected biofilm within that wound bed, so that wound's not progressing, it's quite static, it's stuck in that inflammation stage, maybe there's large levels of exudate, there could be a biofilm there. And then you need to be thinking again about preparing the wound for healing and using your all prep pad to really cleanse and debride and remove those barriers to healing, and then use your wound infection product selection guide and do the sort of 2-week challenge with an antimicrobial treatment to see if that kickstarts and gets that wound progressing. Going straight up back to the top, so is that wound infected? Yes. Are there signs of local infection? Then you would need to do your wound preparation and use your antimicrobial. If there's signs of spreading or systemic infection, you need to be escalating, thinking about could it be sepsis, escalate, maybe get a GP referral if they need antibiotics, or if it's a systemic infection, obviously you would need A&E and really acute support at that point. And again, you can still use your antimicrobial at this point to continue to reduce that bacterial burden within the wound bed. And on the outside of this whole pathway, it's always going back to reassessment. You need to always regularly reassess and see if the treatment you're doing is actually being effective and progressing those wounds. So this is a product choice wound infection selection guide. So as we've spoken about, we've got that all prep pad. So within that all prep pad, we've got that dark grey section, which is for disrupting and removing those barriers to healing. And then on that light grey side, you've got that absorption. It's got unique slits that mean that you can capture and remove that debris straight out of the wound, and reducing that bacterial burden. And then you've got your dressing, your products. So you've got, if there's a superficial wound, you've got Biatain Silicone AG or Biatain AG non-adhesive. So these wounds will have that 3D fit technology that will conform up to 2 centimeters. So you do not need a filler. And that's really important about that simplified approach, that if you've got a wound that's under 2 centimeters, you just need to put the one dressing in place. You do not need to fill it. So if the wound's between 0 to 2 centimeters in depth, you can just use the Biatain Silicone AG or the Biatain AG non-adhesive. If the wound's larger than 2 centimeters or has any undermining or tunneling, then you would pack or fill the area with the biotain alginate AG, and then use your biotain silicone or biotain non-adhesive on the top. So you don't need to use an AG silicone or non-adhesive, because you're getting your silver active agent from the biotain alginate. So following today's session, this is our lovely Georgia, and she will follow up with you on any of the additional support around the products and the services from Coloplast. So you can, we can offer you a follow-up telephone call, and they can discuss face-to-face or virtual education about our products and services. So you can scan the QR code below or click in the link in the chat to submit your details. Our dedicated team will then aim to give you a call around 24 to 48 hours after the event. I've got it in mind, Charlie, if you can't find it. And then we've also just wanted to let you know about the podcast. So wherever you find your podcast, whether that's Spotify, I can't think of any others in a minute, Spotify, Google, Audible, Apple. If you search for
Wound Care Conversations,
you will see that there's 5 podcasts out there. So it's actually myself and Charlie. So yes, if you like a podcast, please do look them up. And you can scan for future webinars again on that QR code that's there. And I think that's it. So I'm going to come off the screen so I can actually see what's going on and stop sharing. Have I stopped sharing yet?
Yes.
Oh, I have. That's good. So we've got a few minutes. Is there any questions that have come through, Charlie, or anything asked or?
No, there's been very little in the chat. You've all been very quiet tonight. But I think if there was anything asked, I have answered it as we've gone along. Lots of people asking about certificates, copies of the slides. So you will get sent a certificate, a copy of the recording, and the pathway after this event. It won't be immediately, but these will be sent to you.
Did you put that link up there?
I've put the Coloplast professional link on.
Oh, okay.
Let's see if I can hear mine.
Yeah. Sorry.
So Gemma has asked if we have any specific training for paediatric wounds. And that's no, currently we don't have any specific training for paediatric wounds, but it may be something that we look at in the future. So just keep an eye on the Coloplast professional website.
So unless anyone's got any questions, I'm going to give you a whole 2 minutes back. I hope you've enjoyed today's session. Thank you so much for coming, because obviously for some of you, you may be doing this in your own time, and we really do appreciate it, and I hope it's been useful for you. Sorry, just trying to post this thing. But yeah, good. I'm pleased. I'm seeing some of the chat now, so I'm pleased it's been really useful. We will have further webinars on, and like I say, if you like me, Charlie, talking to you, then by all means do the podcast. All right, thank you.
Thanks very much. Bye.
Bye.